Um, Good morning, everyone. Thanks, Dr. Arif, for the nice introduction. And I would like to thank Dr. Ayman and the organization committee about inviting me for this nice and beautiful rare disease conference. So I'll try to slightly shift the gear. Dr. Sani addressed the gene therapy. We'll talk about the step after we had already the disease in our gene. By modifying the protein-causing diseases. So we'll try to address and talk about how the discovery happened, what is the role of RNAi, and how it changed the disease. And I will just highlight one of the medication which used in my specialty as a pediatric nephrologist is primary hyperoxaluria PH1. So the discovery actually started the story started in 1990, and that was translated in winning the Nobel Prize for Physiology or Medicine for the two researchers, Andrew Fire and Craig Mallow. This highlights the importance of the discovery and consequences which happened after they introduced the new methodology and technology. So this is a quotation from different members of the Nobel Prizes about the importance of the groundbreaking of these two researchers. Like it was like an opening the blinds in the morning. Suddenly you can see everything clearly. The discovery of RNAi, it's basically changing the concepts of how we're treating patients, how we target the disease, and it, of course, will change the futures. Another important in the discovery that the clinical trial actually started by Alinal here in 2012, and it took them only 6 years to get the approval from FDA and EMA for the first approved medications, bacitracin, which used for hereditary hereditary amyloidosis. Actually, this is fast tracking, showing us the importance of the RNA medications. It's not only because of the technique, but it's showing how it's important. Usually this process between the clinical trial and approval of the drug takes at least for the drug development 12 years, or if not more, but it's only 6 years here. So how it works, all of you know that the cell is the basic structure for our function, physiology, and it form all the types of organs. Our genes are stored in the DNA in form of the chromosomes, which with two processes, which I will show later, will form the protein, which is the blocks that build all our cells in the body. So our cells will have the nucleus, which again will have our DNA, the genetic information coded in the chromosomes. And by two processes, the first is transcription, as all of you are aware, will transfer this information to the mRNA. And by that, the next process will start, which is the translation to form the protein, folded protein, which is in 3D. And that will give us the instruction, the signals, or the enzymes, and to control our function in the body. So if there is any problem in this process, usually we will have a disease, whether at the level of the protein, at the level of the mRNA, or a gene mutation. So, how we make a protein? Protein, all of you know that is combined of amino acids in certain sequences. The RNA and DNA usually formed by 4 nucleotide bases. These nucleotide bases will come in a set of 3 to form the codons after the transcription. And these codons, each of them will represent the amino acids. We have about 20 amino acids. these amino acids, if the order of these amino acids will give you different protein and different function. So if there is a change in these amino acids or the codon, then you will have a disease modifying or disease protein causing, and that will usually cause different types of the disease. The protein is very important. If it's changed, blocked, defect, then you will have different disease. How the mutation happens? So the mutation can happen at any site of the DNA, but there are usually hot spots which usually present and causing the gene mutation. With the transcription, this gene mutation will transfer by the mRNA, and then we will have the misfolded protein, and that will cause the disease. Like an example, in Alzheimer or the amyloidosis, when we have increase in the formation of certain fibrils. And again, if there is a downregulation of some of the enzymes like in PH1 or acute porphyria. So there are three different mechanisms in which the drugs that can target how we treat different diseases. So if we are targeting the protein, then we're trying to remove the protein which causing the disease, and that an example of antibodies and small biologics. Usually this is the end process. But we are all treating the symptoms. We don't treat the disease itself, because the continuation of the forming of this abnormal protein will continue. The second step or the second target in treating any disease is by gene therapy, which I think Dr. Sani addressed that. Our target is to involve the mRNA, which basically down-regulate or up-regulate, stabilize, block, or replace the messenger RNA in the form of RNA interference or antisense oligonucleotide. So RNA basically, what is the job? It's just to stop the signals, so we will not have the misfolded protein, and that is stopping any complications or any disease symptoms, because it stops the process before forming the protein. What is the use of that? Usually it has multiple benefits. It can affect any RNA or messenger RNA, so it will stop the copies and it will not need frequent doses. It can use to target virtually any types of protein, and actually it can upstream or downstream the different proteins. How we deliver the alanine use different approach. Try to minimize the unwanted side effects by targeting the cell, first targeting the tissue, the liver. So in the three diseases which they discovered, or by the RNA interference which they used, usually the diseases are in the liver, and they try to only target the liver. Not only that, but they also targeted the cells within the liver, which is responsible for having abnormal enzymes or protein, and then not the cell itself, but also the site of action of these cells. So it's very specific, and it's just involving the protein, the misfolded protein. And of course, that has effective and has a benefits of unwanted side effects, and infrequent doses, and longer half-life of the medication. So, moving to the primary hyperoxaluria type 1, which is a congenital autosomal recessive disease, usually happens due to enzyme deficiency in the liver. But the first organ to be affected is the kidney. I gave a talk yesterday in details about the primary hyperoxaluria, which I will just discuss briefly here. So what is happening here with primary hyperoxaluria? We have a mutation in the AGT enzyme, which is actually, so we have the liver, glycosylate usually will, through the AGT enzymes, will form pyruvate and glycine. If we have a mutation or a defect in this enzyme, then the glyoxylate will form oxalate through the Go enzymes, okay, which is a glycolate oxidase enzyme. More production of the oxalate will try the kidney will try to get rid of that, and then we will have the primary hyperoxaluria, which is oxalate in the urine. If it's too much and it's for a long time, then we will start to have the manifestation of the disease, which basically the kidney stone, nephrocalcinosis. And if this is progressing, then we will have a kidney failure. Once the patient or the child has impaired kidney function, stage 4 or 5 of chronic kidney disease, then this oxalate overproduction will start to go everywhere in the body, causing systemic oxalosis and precipitate within the heart, the bone, causing anemia, affecting the retina, causing hypothyroidism and other features. There are more than 150 mutations discovered so far, and it is very common in pandemic in our regions because of high consanguinity rate between the families here. So in the Middle East and Northern Africa, it's very consanguine. The prevalence rate is about 1 to 3 in 100 million. And this presentation can start from the severe infantile form to silent adult one. Usually symptoms could be very mild if we are screening the family who has a positive history, but we still can see infants or children presented with recurrent renal stones, UTI, hematuria, and sometimes the severe end-stage renal disease. But the most important here is PH1 is underdiagnosed because of this variety of a presentation or under awareness of the disease itself. So, symptoms and signs are anybody organ can be affected, but usually the kidney will be the first to be started because it tries to get rid of this extra oxalate. So it will have a nephrocalcinosis, kidney stones, kidney failure in the advanced stage. Once we have GFR below 30 ml per ml, then this systemic oxalosis will start and other organs, as I mentioned earlier, will be affected, the retina, the thyroid gland, the heart with ischemia, myocardial infarction, and of course the bone with the fractures, pain, and anemia that not responding to the erythropoietin. So the most common type, there are 3 types of primary hyperoxaluria. Type 1 is the most common in 70% of the cases. There are other type 2 and 3, which usually 10 to 20%, and all are enzyme deficiency or problem with the enzyme within the liver itself. How we diagnose, how we approach the children with that, usually if they are presented with renal stones or hematuria, then we send a spot urine oxalate to creatinine ratio to see if it's high. If it's high and the child is totally trained, then we will move to 24-hour urine collection, which is sometimes challenging. If it's showed that the 24-hour urine collection show high oxalate in the urine, then we send for other labs, and serum oxalate usually, which is in the production of the hyperoxaluria or oxalosis, actually will not be very high initially, especially if you have a normal kidney function. Once we have a decrease in the kidney function, the serum oxalate will start to increase. And of course, by other labs and radiology like ultrasound, which show nephrocalcinosis, and of course the serum oxalate. To confirm the causing or the underlying cause, usually we send for a genetic testing. The genetic testing will start with targeted gene for the AGT enzymes. It's an autosomal recessive, as I mentioned earlier. It's about 70% sensitive. If it's negative, then we go for whole exome sequence, which will be positive in 98% of the cases. Prenatal diagnosis also available in the first trimester by doing a liver biopsy under ultrasound guided, and it's to detect the enzymes level, the liver enzymes level. In the second trimester, sorry, in the first trimester by chorionic villus sampling. And usually, once we do the genetic testing, it will confirm the underlying cause. So, why early diagnosis is very important? As I mentioned, most of these cases are underdiagnosed, or there is a delay in the diagnosis. This will cause catastrophic events, and the child will present with end-stage renal disease. So this one study showed it's like 27 patients retrospectively followed at the time of the diagnosis before they have abnormal kidney function, and it showed clearly that once we start permit treatment and giving them the appropriate management, then that will preserve more of the kidney function delay, the end-stage renal disease, and of course the extrarenal manifestation and systemic oxalosis. So this is the conventional treatment of the PH1. Usually they have, as I mentioned, recurrent renal stones. The treatment for any stone is by overhydration. It's difficult to achieve with kids because of, especially if they are infants, so we sometimes require to put an NG tube or G tube to give them hydration of 2 to 3 liters per day of meter square. We alkaline the urine because calcium oxalate stone is very common in acidic urine. Dietary changes is of limited benefit. If we have advanced stage or recurrent stone, then we remove it by surgically or by lithotripsy. Dialysis in these kids, usually not the routine dialysis 3 times a week, because it's not enough to remove the overproduction of the oxalate. So we need actually frequent hemodialysis daily and for longer duration. And if we reach to the end-stage renal disease, then we move to a kidney transplant, but the outcome is poor because usually the defect is in the liver, is not in the kidney. So they will require actually both liver and kidney transplant. So, Loai is RNAi, which approved in 2020 for use in PH1 in kids and adults. And how it works actually. So as I mentioned earlier, we have a defect in the AGT, so we have more oxalate through the GO enzymes that will lead to overproduction of the oxalate, which will be secreted in the kidney. Loai is acting directly on the GO enzymes, which will stop the production of the production of or the conversion of the glyoxylate to oxalate, and by that we're stopping the underlying cause. So it's approved done by Alinalam, trial Illuminate A and B, which I will show in the next slides, and usually it showed a very good and outstanding results. So there are phase 3 clinical trials for Loai, Illuminate A, B, and C. A, it's a randomized double-blinded placebo-controlled for kids or patients more than 6 years of age with normal kidney function. The Illuminate B, open-label single-arm study for children below 6 years of age, but still with relatively normal function. For the C, it's open-label single-arm study with impaired kidney function below 45 or elevated creatinine for the age. We are at Al Jalila are participating in this clinical trial C currently. So Illuminate A showed that there is a significant drop of the serum oxalate or the urinary oxalate, 24-hour urinary oxalate, as compared with the placebo, about 50%, and that in the first 6 months of the study. So all the patients enrolled in the first 6 months, and they usually followed for 54 months. While Illuminate B confirmed the decrease in the serum oxalate and the decrease in the kidney stone formation or the worsening of the nephrocalcinosis. Illuminate C had two cohorts. One, as you remember, the Illuminate C is with impaired kidney function. Patient A, cohort A, is not receiving dialysis. The other is receiving hemodialysis and is still ongoing. But the first initial preliminary results showed good outcome with decrease in the urine and the serum oxalate in both, and decrease in the secondary complication. So the other two RNA which discovered also one to treat the hereditary amyloidosis, which is a rapidly progressive disease, also affecting other organs, but basically the defect is in the liver, is through batisaran, which usually approved in 2018. The other systemic diseases, acute hepatic porphyria, again defect in the liver, multi-organ involvement, and givosiran is the